Okay, well, welcome to the Vascular Radcliffe podcast. I'm Laura Redman, and I'm taking over the veinPODCAST from Steve Elias, all the way from South Africa. And my interest is vein and lymphatics. That's where my whole practice is dedicated to. So we're starting the podcast actually with the topic of lymphedema. And we're going to look at the real understanding of lymphedema and patient satisfaction. And on the podcast today, I have Dr. Håkan Brorson, all the way from Malmö in Sweden, who's pioneered a lot in lymphedema and the treatment thereof, and Suzie Davey, who's a lymphedema therapist, a specialized therapist, an occupational therapist as well, and she sort of got lymphedema going in South Africa, and we both have been to train with Dr. Brorson in Sweden. So I think what we'll do is just start with you, Håkan, if you can give a little bit of an overview about all your research you did many years ago in how you got to understanding the real pathophysiology of lymphedema, and that it's not just abnormal fat in the Swedes, as you presented before. A bit about that initial research.
Okay, well, actually, it started in the mid-90s, and I presented the first 28 cases I operated on. That was patients with arm lymphedema following breast cancer treatment. That presentation was in Madrid in 1997. And I show all these patients with very large arm lymphodemas up to about 2.5 liters, that they were completely reduced within 3 to 6 months. And it stayed there during that follow-up time, which was about 2 to 3 years. And people thought I had manipulated my pictures because complete reduction of chronic, very large lymphodemas were not possible before. And then I heard a few comments, as I mentioned to you before, that maybe that is due to that Swedes eat different food than around the Mediterranean, or I have never seen it. That must be something peculiar for Swedes. And a third guy said that liposuction for lymphedema is science fiction. And that gave me the force to show what I've seen clinically in the operating room when we just remove fat. Because we remove fat from non-pitting edemas. And the patients are treated conservatively to get rid of all the fluid. And we use a pitting test. We press as hard as possible for 2 to 3 minutes on the forearm or lower leg, and really press hard up to the pain threshold of the patient. Mm-hmm. And then we estimate the depth of the pit in millimeters. So if we have, like say 4 or 5 millimeters in an arm or 5, 6 in a leg, then we know that most of the excess volume is adipose tissue.
I'm just going to interrupt you a second there, because one of the questions or things that still aren't very well accepted in some centers is that there's actual adipose tissue. And I mean, I know you've done that research as well, and we've seen it and we've taken it out. But that was part of your research as well, as actually proving that it's adipose and not just fibrous tissue there.
Yes. So we went into research and showed with computer tomography and dual emission X-ray absorptiometry that there was around 80% excess fat in non-pitting lymphedema. So we continue with the liposuction, and we now have 25 years follow-up for arms and more than 15 years for legs, and no patient is lost to follow-up. So we have keep track on them all the time. And there is still no recurrence, provided that they use the compression garments as we have prescribed 24/7, and that they get the amount of garments that is needed. It's like, for example, if you have diabetes, you have to individualize the amount of units of insulin that you give. Some needs fewer units and some needs more. For example, a 70-year-old lady active might need 2 garments every 6 months, while a young man with a metastasis of melanoma in the axilla and has been treated needs 2 garments every 3 months or 1 month. So during the first 1 or 2 years, we see how much does this particular patient need in order to keep this fluid to recur. And then we send the patient back to their therapists all over Sweden and also abroad. And once a year at least, I get volume measurements, and they are put into our quality program, so I can follow them even if I don't see them. And the reason for adipose tissue is that lymphedema leads to chronic inflammation. And when I published my papers, there were papers coming up now doing these in animal models. And there you can also see that there is excess adipose tissue. So if an untreated lymphedema has around 50% fluid and 50% fat, then you then remove the fluid. And if the arm or leg are still large and cumbersome for the patient, then you can carry on with liposuction. Looking in the textbooks, going back, it said that it's just fibrosis. And it's quite rare I see the fibrosis, because I see it more in male patients in the lower leg and in the females with a more masculine deposition of fat or distribution of fat. But that's quite rare. Of course, there might be some very fibrotic lymphodemas, but since we use power-assisted liposuction, we can penetrate those fibrotic areas and get rid of the fat. And also the rigorous compression we have afterwards. If you have a scar, you can treat it with compression, and fibrous tissue is like a scar, so that might also influence the decrease of fibrous tissue. It's very difficult to measure fibrous tissue because it has the same density as fluid, so it's difficult. So this is how we work in Malmö, and we are now doing genetic studies of the fat together with Kari Alitalo's lab in Finland, and we hope to publish these data soon.
And have you found an actual difference in the type of fat, apart from it being more fibrous? That is deposited?
Yeah, we recently published a couple of months ago that what you would expect actually, that fat cells in lymphedema are larger than in the control side. So the patient is its own control, and also that fat cells in the arms are larger than in the leg. But it's more academic knowledge, so to say. You need still to treat these patients. And for example, leg lymphedema patients, we use double compression. We have almost flat knitted. So 2 weeks before surgery, we take measurements on the healthy arm or leg and get the garment within about a week. So we use 3 garments. One is sterilized, and that just used for 2 days. And on the second day after the surgery, we put on a class 3 garment, and then daytime on top of that, a class 2. And during nighttime, they can sleep with either class 2 or 3. And then after patient has come home after a week, they change every other day. They are in hospital for 4 days. So they change every day. So every morning they take on a clean shrunk garment, class 2 and 3. And in the evening, they remove one of them. So it's important that they have 2 garments of each. And then the durability of these, as I said before, can depend from 3 to 6 months, but not longer.
Okay, and we'll come back a little bit to that just now. I just want to also get Suzie a bit involved here. So I think we both trained under you in order to bring this technique of, we call it debulking, in South Africa. And you've trained units together. One of your prerequisites is that you go as a team to train. And I think that's a key thing, and that it's not just a surgical procedure, that you need the team approach, because most of the management actually comes from the compression garment itself, and the pre-op and post-op preparation. So I don't know if Suzie, if you just want to comment a little bit on that part of the procedure.
So the fact that I think it's fabulous that we did have to go as a team. Thank you, Håkan, for encouraging teams to come together, because obviously with regards to doing the treatment for the liposuction and the debulking, the compression aspect of ensuring that the patients are compliant and really understanding the whole process of what the debulking is all about, right? Because the liposuction is just one aspect, but the whole the treatment before, having the patient go through with regards to the conservative treatment that Håkan had mentioned, how important that is, that the patient has to be reduced as much as possible beforehand, before having the liposuction procedure. And we've noted that as well, where, you know, when you do that, the compression, the checking the pitting edema and holding it for 2 to 3 minutes and really seeing if there's still pitting edema, how vital that is, because one can hold for just 10 seconds and really say, oh, this patient doesn't have a lot of pitting. But when you actually do the pitting edema test properly, to really decipher how much pitting is there, and then to properly do the complete decongestive therapy to really reduce the patient to a state where they're prepared for the surgery, I think is so important. And I think we've been successful thus far in the few patients that we've had to get that right. And then with regards to fitting the patients for the compression garments has been a learning curve, and it's been really interesting because, you know, in traditional therapy training, we're taught that a patient is never supposed to sleep with over compression class 2 garments. And coming to your clinic in Sweden, in Malmö, you know, I was visiting you and we had a few days of training and seeing those patients who are actually wearing much higher levels of compression at night for sleeping, compression class 3 and some even compression class 4, successfully and without any complications or having any problems, was really a very interesting and eye-opening experience.
You mentioned a good point there, because I kind of also wanted to bring up with that very strong compression that you do. Essentially, you must be reducing microfiltration and reduction of actual lymph formation. Is that correct?
Well, that is a thought. I mean, you know, we don't use MLD, which is a part of CDT, because I have 45 papers that have shown that the MLD part of CDT does not contribute to volume reduction. And the latest publication about this was by James Armour now in July. Anyhow, so what we did in the beginning, we had patients that had a lot of pitting. So we used what we kind of invented, the controlled compression therapy, where we took in the garments. We had a kind of randomized study. So we took in the garments and saw the patient maybe every 3, 4, 5 weeks. And some patients were very good at taking in the garment by taking a more narrow measurements on their garment. So they could come back after 5, 6 weeks with 3 to 4 seams on their compression garment. That helps a lot, because then they could be back on work. And if you do the bandaging, which is also very good, but sometimes it's quite bulky and the patient cannot work during this time. So we found this much easier. But nowadays, when we have a referral, I ask for the name of the therapist, and then I send an email to her or him to tell what we want. We want the patient to have minimal pitting, and that they, before the patient comes to us, get used to wearing 2 layers of garments daytime. And by that, the patient has been accustomed to wear it 24/7. Sometimes they have just been using it daytime, but now they are mentally ready to have 2 garments on, and it has helped us a lot. I don't see a patient before I get the excess volumes, the amount of pitting, and what kind of garments and how many garments are prescribed for a certain time period.
Yeah, I think that is key. And I think I only realized that when Suzie bought the bandaging, you didn't realize what a huge difference that decongestive therapy makes to really get that fluid out. And you're right about the patient preparation. in order to achieve those correct outcomes. Suzie,
and also the larger the lymphedema, the more motivated the patient is to really go into this. If you just have, I mean, our limit is 10% excess volume. And I mean, if we have one with 50%, they really want to do this. And also, I don't operate leg lymphodemas with a BMI that is over 30, where we also deduct the excess volume. So if you are like 90 kilograms and the excess volume is 4 liters, we deduct 4 kilograms from the patient's weight, and then we calculate the BMI. And if it's over BMI, they have to lose weight, because when the leg gets larger, according to Laplace law, the pressure is inversely related to the radius or diameter. And when you have this large thighs, even if you had triple compression, it doesn't give that compression you want. So we want them down to a BMI less than 30, and then it works fine.
So it's more for the compression use for the BMI. Okay.
Yeah.
Okay, excellent. And I must say, I think after doing this, you say it's a debulking. So it's, I mean, it's quite an intense procedure, but not that technical. But from my side, I've never had happier patients with a more positive outcome in any type of surgery.
I agree. I'm an orthopedic surgeon from the start. I put in knee and hip prosthesis, and patients said, okay, that's good. But when I came into lymphedema, they're quite different. They have been having this for a very long time. And when they see the reduction, they are very, very happy.
No, I think it has been the most rewarding. Suzie, do you want to chat a little bit about the patient selection and preparation? Because I think we've learned a few things about that here in terms of outcomes.
Yes. So, like as you've pointed out, Håkan pointed out, I think we are in disagreement with regards to the manual lymph drainage portion of the preparation, but everybody has the right to their own opinion. I do think with regards to the lymphatic drainage, whether it actually helps to reduce the volume or it actually helps to decongest the tissue and soften and remold the tissue integrity. I mean, we can feel it with our hands when we're actually doing it. And whether that could happen solely with the bandaging and without the manual lymph drainage, I've always done it together, so it's hard to decipher that. But
it's like a religion.
Yeah.
And I've been to the further clinic, and I asked them, why do you use MLD? I have 45 papers that states that the massage component does not contribute to the volume reduction. And if you skip that, you can treat maybe 2 or 3 times more patients. And the doctor said that, well, you can't change it because it's in the walls here. But he agreed to the statement.
I think maybe Suzie has a point. I don't think it's not going to make that huge difference in volume reduction, but maybe for the tissue, the skin consistency and
absolutely. With the tissue integrity and just, you can feel it. I just, the softening of the tissue is a whole nother level when you add the component of lymphatic drainage. But I think that's a conversation maybe for another podcast that we can debate this. There's a lot of papers that actually show the benefits of manual lymph drainage, and yes, you can pull up just as many, if not more, papers that refute how successful or how effective lymphatic drainage is. But the bottom line is that it is a component for now in most places, and there's thousands and thousands of therapists worldwide that make their living off of doing this, and patients do buy into it, and they do feel results, and they do feel relaxation, and there's value to having that effect on the patient as opposed to just doing bandaging. And so, but with regards to the preparation of the patients, that Laura and I have definitely seen with the patients here in South Africa, I think the biggest component that the takeaway for me is that how important it is. I think that once the patients are reduced with the conservative treatment, whether that involves lymphatic drainage or just the bandaging, but most patients are having lymph drainage with bandaging, I think that getting them into that flat knit compression, right? Because that's what you always recommend. It's not about circular knit, it's about really that containing. It's about having a garment that's going to contain the reduction. And with flat knit, it is the ultimate, the ideal, best quality type of garment that's going to be comfortable for the patient and safe for the patient to wear 24 hours, as opposed to a circular knit. And I think that the factor of the containment is what's important. So getting them fitted once they reduce before surgery and getting them fitted for a compression garment for daytime and nighttime has been, in the few patients that we have done thus far, has been what has led to their success, or part of their success levels is that they were using compression for day and night before they came into the surgery. So like you mentioned, it's really a psychological preparation, because it's one thing to say, yeah, I'll do whatever you say, but actually having to wear a compression for daytime and nighttime is a whole different experience. And I think a lot of patients are so desperate, they'll say they'll do whatever you need them to do, but they actually need to do it and to feel it and to live it and to understand what it actually entails, so that you are going to have a higher level of success. And I think, part of it is you want to do a procedure that the patient is going to be able to be successful in. And you've proven that, Håkan, with all of your years of experience. But I think in my opinion, I think it's crucial that patients really understand what they're getting themselves into, that the garments, they have to be able to afford lifelong the garments to be able to be replaced for daytime and nighttime. And I suppose at some point they could bandage themselves at night if they, on occasion, if the garment is feeling too tight and they're not comfortable. But ultimately they have to have compression daytime and nighttime, and flat knit is the easiest thing to be able to don and doff, ultimately.
After surgery, we use no other things than the compression, no MLD or CDT.
Yeah.
And I think the MLD component has another psychological benefit, that the patient, if you are close to the patient, they feel the touch and the release of these well-being hormones.
Yes.
It's like go to the hairdresser and get your hair washed, and you talk about gossip and things like that. And it's something that we forget, but looking at volume reduction, it has no change according to what they have written in the papers. That's it.
Well, I'll have to do more research then to prove how effective MLD is, because I think that we have to structure the study properly.
Yeah. But I know that it's difficult to change something that has been learned in school. And if you skip the MLD part, it doesn't, because this is very strict when you learn it, and it's difficult. I mean, in Sweden, no lymph therapists or physiotherapists or occupational therapists use MLD in the hospitals. There are some private ones that just do massage and no compression, and that is crazy.
Yeah, you'll have to do a skin study. I think the post-op, that idea is really that really tight compression to stop lymph formation again. Sort of like in the giraffe leg, we always learn about that. And then part of this treatment, which I said is so satisfactory for patients and has been so rewarding, in that there is a bit of a shift in medicine, not that all treatment must be limb or life-saving, but more improvement of quality of life. And I think that's also how it came about. And after doing our first patient who had severe lymphedema from radiotherapy and a groin lymph node dissection, she reported back on the improvement of quality of life, because she was fit and healthy and in good shape, but it was difficult to exercise. She couldn't wear shoes, she couldn't wear clothes, has a psychosocial effect, they get infection. And that difference of, I think, how things had changed, you could see, their whole lives change, and that they're more motivated for everything, they're happier with their family. It's small things they can do. I remember saying she hadn't worn a shoe for 8 winters and always had a cold foot because nothing fitted in it. So a lot of them are secondary lymphedema, as you know, more than the primary. And we're wondering, do you have focus in Sweden or in Europe on picking lymphedema up early if it's post-surgery for breast cancer, auxiliary surgery, or in the groin? Do you monitor them or do any preventative work?
Yes, they are followed by general surgeons and lymph therapists affiliated, mostly done, I think, in university hospitals. And they use volume measurement. They also use moisture meter, and some use bioimpedance, but most maybe feel that moisture meter is easier. I mean, you could detect more fluid in an arm or leg that does not yet show any volume difference. But we just take those patients that have had the conservative treatment with minimal pitting. So it's not up to us as plastic surgeons to follow them. It's their breast cancer surgeon that has to do that. And it varies from hospital to hospital. But all hospitals have a lymphedema therapist. But going back 30 years ago, there were very little of that.
Yeah, I think that's an area that definitely needs more awareness, because if that slight increase in size was detected, you know, they could get better garments or something from the beginning to sort of avoid this. And that's why we're going to get an oncologist on who can't get on now. We referred a patient, though, she had stage 4 breast cancer and had radiotherapy before, and the lymphedema was more worrying for her than anything, more dysfunctional. So I think it's such an important aspect to treat.
Yes, we have also studied quality of life in patients with arm and leg lymphedema, and there is a significant increase in quality of life after liposuction due to the volume reduction. And I remember one patient from Australia that we operated on in Sydney, and she had more than 12 liters in her leg, and after 6 months she could not even walk up the 8 steps to the outpatient clinic, and then she sent a small video from Sydney Harbour Bridge, 1,390 steps after 3 months, and that was great. And she did a around the world trip. She lost 50 kilograms. She was a runner before and has started running now, so she was very happy.
No, it's really fantastic.
Yeah. Our patient here in South Africa, also the first liposuction patient, lower extremity, she's running her first marathon, I think, on the 17th of October, coming, or this week, or whatever weekend it is that falls.
Do you have a picture of when she's coming to the?
Yes, I will be there.
Yeah, she will, or she has already run.
No, she's going to be running, so I'll have to be there.
Okay, you have to take a photo. Yeah,
definitely.
Send it to me as well.
Which race is that? Which marathon?
In Cape Town. I don't know. It's definitely I don't know the name of it. Two Oceans, is that it? The 2 Oceans Marathon.
Okay, she's running. Excellent, fantastic. And in South Africa, the big thing is the expense, but that's what we're trying to motivate as well. Because I mean, with this whole pathophysiology, it's not a cosmetic procedure, and I think that's what we're trying to get medical aids and medical insurance on board. It's exactly like the old school idea of debulking, those Charles procedures and those barbaric procedures, but now, you know, you're keeping that skin intact, which is important.
Yeah, we are lucky in Sweden, so the patient pay out of pocket 30 euro for a 1 hour visit, and then they get their garments free.
Wow.
Yeah, that's really great. Especially because
it's like usually say that if you go to the internal medicine diabetes doctor, he says you get just 1 vial of insulin for 6 months. This patient will end up in the emergency after a couple of weeks. So it's a medicine and should not be regarded as a static thing that lasts forever.
Yeah, that's a good argument.
And it's used for 6 months, so it's a medicine that's used for 6 months. It's not a once-off. So if you break it down to how much it actually costs per day, if it was a pill that you had to wear per day, I mean, it's actually quite a reasonable expense, as opposed to them being hospitalized for recurrent cellulitis infections or other medical complications that happen down the road with these complications of the lymphedema and health issues that develop from it.
Yeah, I think, and the long-term effects are often overlooked. It's everyone's reported on them being more active, so they're going to prevent obesity, cardiovascular disease, psychosocial, the whole thing. Yeah, I think ultimately the cost saving is worthwhile.
Yes, and we also published a paper regarding bouts of erysipelas before and after lymphedema, and the number of bouts per person per year was reduced by 87%.
I kind of wanted to ask you again about your research, and there was an article I read in, I think it was in Nature, about them looking for the adipogenic factor that causes lymphedema, and some described inflammation and some described free fatty acids as a potential cause. Do you think that's a possibility?
Well, if it's written in Nature, you have to go for it. But according to what I've read so far, it's the lymph fluid that is in the interstices between the skin and the muscle. If you measure inflammatory molecules there, they are there. And these inflammatory molecules are then upregulating the genes responsible for transferring precursor fat cells to normal fat cells. That is, I think, the ongoing thing right now. But of course, free fatty acids, there is no paper yet that has shown that any diet has to do anything with decreasing lymphedema, other than if you lose weight and the excess volume will decrease. But it's an inflammatory reaction, and also that this kind of speeds up the inflammation, low-grade inflammation that upregulates these adipose genes.
Yeah, no, I don't think it was a proven thing, just a suggestion. It might also be that they're more toxic and stimulate inflammation if they've leaked out of the lymph.
Yeah, maybe. But the free fatty acids is more from the gastrointestinal tract, not from the arms or legs. I mean, you have the lymphatics from the guts that take up the fatty acids. But I don't think you have that in arms or legs.
Yeah, they were starting to find things that weren't thought were there, but I think a lot is still unknown.
Yeah, sure it is.
Yeah. Do you think there's any potential for stem cell, adipose stem cell injection to regenerate lymph?
That was an interesting question. I was the opponent of a thesis in Denmark 3 years ago, where they took stem cells and injected it into the axilla. And the outcome was nothing happened.
Okay. Yeah. I think
and then we have the BioBridge, which is now promoted from a big company in the States, where you have this scaffolding that you kind of go from the armpit and out from the arm and out to the lymphatic tissue. But that still needs to be proven that it works. I don't believe in it personally. And then you have the injection of vascular endothelial growth factor C into lymph nodes or into the area where, let's say, in the axilla, to facilitate the growth of lymphatics. And animal studies made this, showed that there is kind of sprouting of the lymphatics. But the problem is VEGF-C has a very short half-time duration. So then they infect it together with a virus to keep it longer.
Okay.
And then you see a little more sprouting in the mice, but they never catch up with the lymph node. And if it doesn't work in mice, I'm not sure it works in men. But there are ongoing studies. We will see. These are done in Finland and in conjunction with Stockholm and Uppsala.
Okay, yeah, I think it's an area that's becoming more of interest and more researched. And I think I must just ask you, as you're a plastic surgeon, and we've discussed all this, if you'll just make a comment on the microsurgical techniques for lymphedema.
Yes, I can say, how long do you want me to talk? I'll make it short. Okay, so I was at the World Congress on Lymphology in Athens. I've been to many societies like American Society for Reconstructive Microsurgery. I've been in the panels there. And I noticed that during the years, they also do liposuction in conjunction with a microvascular procedure, like lymph node transfer or LVAs, like lymphovenous anastomosis. And they do it in patients with pitting edema. And they put compression on afterwards, and they say, look how nice reduction we have. And I ask them, is it due to the LVAs or lymph node transfer? Is it due to that you have compression afterwards, or is it due to liposuction? And well, that's a combination, maybe. And so forth. So why don't you do microsurgery in Sweden for lymphedema? I said it doesn't work, because if you look at the lymph vessel in the 4 stages, the first stage is when you just cut the lymphatics. Then you might be able to connect the lymphatics with veins, adjacent veins. And that is doing now with the lympha procedure, which comes from Italy and Francesco Boccardo, and also done in a few places in the United States. Still, about 5% of them get lymphedema, just as many as get lymphedema after this sentinel node technique. Mm-hmm. If you go to the second stage with the dilatation, well, then the lymphatics and the valves are coming apart. So these lymphatics are already incompetent, like veins are incompetent. And then you go to the third stage with more fibrosis, when the smooth muscle cells in the walls became fibrotic and the normal pumping mechanism does not work. And then the fourth stage, you have these lymphatics like eels in rigor mortis. They're completely stiff, they don't move, and they are occluded. So if you should do microsurgery, it should be done when you remove the lymph nodes, but still we need to have a long time follow-ups. And then we also should know that not all patients get lymphedema. So should you do it in 100% of the patients, or how to select these patients that maybe already before the breast cancer treatment has a decreased lymphatic transport. That has been shown by Peter Mortimer in London. He did lithoscintigraphy on normal arms and the arm where the patient should remove the lymph glands. And he showed that in the normal arm, there was delayed transport. So that's another thing to think of. And for the United States, if you ask the insurance company, I want to do reconstructive liposuction. If they hear the word liposuction, it's no. But if you do reconstructive lymphovenous transfer or lymph node transfer, then you get money, and then you do for free liposuction to get the results. And I can tell you, Corinne Becker started with the lymph node transfers. And strange enough, when you hear her, I heard her now in Athens, she said, there are no complications, everybody get nice legs and arms. There were actually a doctor in physiotherapy, a physician who followed 28 of these patients. And they actually had 1,058 milliliters before excess volume and the same after lymph node transfer. 7 had a donor site lymphedema in the leg where they had taken the lymph nodes from the inguinal region. 5 had lymphoceles, 4 had persistent donor site pain. And there are also other, from Barcelona, they also reported cases, also from Helsinki with the problem with lymphedema where you take the lymph nodes. So I think it's like I would say that it's an experimental surgery, and we still want to have this honest surgeon that really shows out the long-term results. And I have a slide that I tell them, have compression on before you do the procedure and remove the garment for 1 week, and you remeasure the excess volume and it's gone up. And then you put the garment on again and remeasure after 2 weeks, and it's gone back to the baseline. Now you do your microvascular procedure. You put the garment on afterwards, and then after 3 months, you remove the garment. If there's no increase, microsurgery is successful. If it increases, it's not successful. Nobody has done that before, and still waiting for that.
Okay. Okay, thank you. So I think we're going to have to wrap up now because of time. It's a topic we could speak for hours on, but I want to first thank you both very much for joining. And I must just say a little summary on the whole lymphedema, so I think the listeners will understand. Well, the primary and secondary lymphedema fluid will eventually change to adipose tissue, and the only way to get rid of that really is by liposuction and debulking it in that way. And a patient needs to be well prepared pre-op to get all the fluid out, and well prepared for post-op to wear the correct garments lifelong, day and night. So a team approach is very necessary. But there are the most satisfying operations and the happiest patients, I think. So thank you again, Håkan and Suzie, for joining, and I hope we can have further discussions in the future. And we just need to create more awareness of this treatment and its outcomes. Yes. And then, thank you. And
thank you.
We'll have our next web podcast is venous disease overtreated. So a bit on the other side of the spectrum, find a treating lymphedema. Okay, thanks so much.
Thank you, Laura.
Okay, thank you.
Bye.
Bye-bye.
Bye.
Thank you.